Good morning, everyone. We are really excited to have Dr. Heather Walker here from all the way from Scotland, present to us about CKD and the complexities of multimorbidity. Dr. Walker is a renal and general medicine trainee in the NHS in Dundee, and with a SCREDS Clinical Lectureship post in renal medicine at the university. She has done her undergrad and medical training. Currently, she's doing a clinical research fellowship in Glasgow, a PhD as part of the Wellcome Trust funded PhD program. So welcome, Heather.
Thank you, and good morning, and I guess good afternoon from here. And thank you for that lovely introduction. It is an absolute pleasure to be invited to speak today at your Grand Rounds. And as Swapnil's already said, I'm going to be speaking about CKD and the complexities of multimorbidity. So I have no financial disclosures or conflicts of interest to declare. But just to go over what I'm going to cover today and what I hope you'll take away from the presentation and the discussions afterwards are the understanding of multimorbidity definitions and the adverse outcomes that it's associated with and its impact in chronic kidney disease. And due to the overlap between multimorbidity and frailty, I think it's really difficult to talk about multimorbidity without at least touching on frailty. I'm aware that it's a topic that's been discussed at your Grand Rounds before, but I'm going to just touch a little bit on the methods of frailty assessment, the adverse outcomes it's associated with, and again, the impact in CKD, and then finish just by considering the future research needs in relation to multimorbidity, frailty, and kidney disease. So this visual is taken from the KDIGO 2024 Clinical Practice Guidelines for the Evaluation and Management of CKD, and it highlights the areas where special considerations is required across the lifespan when we're thinking about managing and treating CKD. And the area of focus for today is predominantly at the end of the lifespan in the diagram, but I just wanted to highlight that multimorbidity and frailty are not mutually exclusive to older adults, and I think it's really important to remember that when we speak about both multimorbidity and frailty, we need to be aware that they're likely to impact individuals with chronic kidney disease at an earlier time point than in individuals without chronic kidney disease. And in younger individuals, they might also have different consequences and considerations compared to older adults. So just want to have that in the back of people's heads when we're going through the presentation today. So to take it back to a very simple definition of what multimorbidity is, there's now consensus that from both the public and professionals that multimorbidity is defined as the coexistence of two or more long-term health conditions in an individual. It's a fairly new concept, having come to the forefront of research in the last decade or so, but for a long time we've spoken about comorbidities and the different interactions between conditions, but really multimorbidity aims to be a more holistic concept opposed to focusing on a single condition and the conditions that occur around that. Multimorbidity is associated with a number of adverse outcomes, including the increased risk of mortality and hospitalizations, and is associated with significant treatment burden in many individuals, on top of them already managing symptom burdens from the multiple long-term conditions that they live with. And what I will say at this point as well is that there's a general move away from using the term multimorbidity, particularly when talking to patients and members of the public, and that's come from feedback from them that they really don't like the term multimorbidity, and specifically the morbidity aspect of the terminology because they associate it with death. And there's a move to using the term multiple long-term conditions, or MLTC, in research now and when we're speaking to patients. So you're likely to read or hear both terms being used interchangeably, and I will refer to both throughout the presentation. So this is one of the seminal papers in multimorbidity research published in The Lancet in 2012 by Karen Barnett et al., where they looked at the prevalence of multimorbidity across both age and socioeconomic strata. And this graph has age groups along the x-axis with the percentage of patients with multiple long-term conditions along the y-axis. And as you can see, the prevalence of multiple long-term conditions increases with age, but there's also significant differences in the prevalence based on socioeconomic status. So the black line represents individuals from the least socioeconomically deprived backgrounds, and the red line are those from the highest socioeconomically deprived backgrounds. And what's really striking is that when you get to around middle age, individuals from the most deprived socioeconomically deprived backgrounds develop their multimorbidity around 10 to 15 years earlier than their counterparts in the least socioeconomically deprived backgrounds. So it's really quite a big difference. Another area of focus within multimorbidity research is trying to establish consensus around which long-term conditions should be included in definitions of multimorbidity and how we assess and code for these within big data and epidemiological research. And a systematic review conducted by Iris Ho and Bruce Guthrie at the University of Edinburgh in the UK showed that there's huge variation both in terms of the measurement and reporting of multimorbidity in the literature, which makes comparison and reproducibility of studies really difficult. And this figure on the right is taken from the review, and it shows the proportion of different long-term conditions that were reported in the identified studies, with the most common conditions being cardiovascular conditions at the top in the red, diabetes being the biggest orange bar, cancer in the navy blue further down, and COPD in the pale green, depression, the purple, but with no single condition consistently being reported across studies or being included in multimorbidity definitions. And obviously, I can't forego mentioning where do the kidneys come in all of this. And here, highlighted by the red box and the yellow bar, we see that less than 50% of the included studies were reported or included chronic kidney disease as a long-term condition within their multimorbidity definition, despite us knowing the multi-system effects, the long-term outcomes, and the impact that having CKD can have on individuals, both in the context of concordant and discordant long-term health conditions. So the same team went on to conduct a Delphi study to establish both professional and public consensus on what conditions should be included within a multimorbidity definition, to help guide and facilitate consistent definitions and measurements that are used in future MLTC research. And they gained consensus on a specific list of long-term conditions which should be included, and came up with 24 long-term conditions always to include and 35 long-term conditions that should be included unless there's a very good reason not to. But they also very helpfully defined and developed a summary of the attributes that long-term conditions should have when you're considering if they should be included within multimorbidity research, which is what this figure on the right shows. And so they said that the conditions should last for 12 or more months. They should be currently active and permanent in effect. They should be considered for inclusion if they require current treatment or care, or if they're undergoing ongoing surveillance, or if the conditions are relapsing or remitting in nature. But also that you should consider including conditions that are associated with the adverse outcomes of death, if they impact quality of life, those that cause frailty or disability, and those that increase treatment burden or worsen mental health. So I think very useful in terms of thinking about whether a condition should be included or not. And then work published just a couple of years ago by Claire McRae and again by Bruce Guthrie in Edinburgh showed that the different definitions of conditions that should be included does result in differences, large differences in the multimorbidity prevalence. And they recommended using one of three condition lists with the highest multimorbidity prevalence, these being the definition by Fortin et al., which includes 27 conditions, Barnett et al., which is that one that's used in that early Lancet paper, and then the Ho et al. Definition, which is the one that comes from the consensus study that I mentioned. And in terms of how that's utilised within multimorbidity research, the Barnett definition in particular has been well validated for use in administrative research data, but similar work is being done to develop and validate coding to use the whole Delphi consensus list as well. There are, however, other multimorbidity definitions that are used in the research and in clinical practice that are worth mentioning. These don't yet have clear consensus around them, but I think are important, particularly clinically. So complex multimorbidity is typically where there's presence of 3 or more long-term conditions in 3 or more body systems, or sometimes referred to as 3+ from 3+. Mixed mental and physical multimorbidity. And then multiple morbidity with multiple complex needs, and this encompasses issues such as homelessness or substance use, crime or severe mental health problems, which will particularly impact outcomes and ability for people to manage their long-term conditions. And then cardiometabolic multimorbidity, which is particularly relevant and prevalent in individuals with CKD. And I've mentioned treatment burden a few times and as one of the adverse outcomes that's associated with multimorbidity. And I just wanted to go into some further detail about this because I'm aware it may not be a concept or terminology that everyone's familiar with. So treatment burden just refers to the work that individuals or their caregivers have to undertake in relation to managing or treating their long-term conditions and can include a number of different things such as lifestyle or behaviour changes, such as dietary changes or as asking individuals to increase how much they're exercising, can include monitoring and managing symptoms such as monitoring blood sugars or monitoring blood pressure and then relaying this information to medical and professionals. And this is increasingly reliant on digital technology, which might appear a good solution, but can often itself result in increased burden for those that might struggle with digital technologies or people that are digitally excluded. Treatment burden can include coordinating complex treatment plans or polypharmacy that typically individuals with multiple long-term conditions will also have, can be navigating complex healthcare or administration systems, which are typically in our current sort of healthcare systems set up to manage single disease conditions, and there's often a lack of continuity of care or people experience fragmented care. And all of this can result in cumulative burden on people that have got multiple long-term conditions or their support networks. And managing and living with long-term conditions can have both time and financial costs and often necessitates high levels of numeracy, literacy and executive functioning skills that individuals may not have. And treatment burden and the ability for individuals to cope with these factors will vary between individuals, and it's related to individuals' capacity to be able to cope with these things, and is something that's not necessarily a static phenomenon. So individuals might at one point in their lifetime manage really well with the treatments and their sort of self-management of the long-term conditions, but something may change in their life that means that they don't then have the capacity to deal with that. And so it's often something that can fluctuate over the course of their life and over the course of them developing different conditions. And I think it's worth saying I don't think all treatment burden is unreasonable or avoidable, but I do think it's something that we need to be very conscious of and that we should try and address, as again, it's a process that will disproportionately affect individuals from more socioeconomically disadvantaged backgrounds and that will further impact outcomes in people with multimorbidity. But so what? This is obviously nephrology grand rounds, and why do I think nephrologists should care about multimorbidity as well as the kidneys? So I've touched on it a little bit, but I just want to go into a little bit more detail about how multimorbidity is important in the context of chronic kidney disease. So this is a cross-sectional study performed using Scottish primary care data where they demonstrated that nearly 88% of all people with chronic kidney disease had 2 or more long-term conditions, compared to just under 30% in those with no chronic kidney disease. And after adjusting for age, sex and deprivation, individuals with CKD were nearly 42 times more likely to have 7 or more long-term conditions compared to those with no CKD. So I think this study just really highlights that multimorbidity is extremely prevalent in our patient population. So this is work from Mike Sullivan from our team in Glasgow using data from UK Biobank, the large research cohort with around 500,000 individuals recruited from across the UK. And this was a study that looked at associations between multimorbidity and the risk of major adverse kidney events. So this is comprised of kidney replacement therapy for long-term kidney failure, a doubling of baseline serum creatinine, a sustained decline in EGFR to less than 15, and a decline in baseline EGFR of more than 30%. And what the study showed was that as the number of long-term conditions individuals had increased, their risk of experiencing major adverse kidney events also increased, and that in particular cardiometabolic long-term conditions were associated with an increased risk of major adverse kidney events. Then further work also from Mike using SAIL, which is Welsh routinely collected primary care data with around 1.6 million participants, and using UK Biobank again. They looked at the number of long-term conditions individuals had with CKD compared to those without, and again showed that patients with chronic kidney disease had an increased number of long-term conditions. They then went on to look at the associations between having multimorbidity and emergency hospitalisations, and found that with increasing number of long-term conditions, there was associations with increased numbers of hospitalisations, and that the rates of hospitalisations were higher in those that had CKD compared to those without. They also then examined how hospitalisations were impacted by the type of long-term or the groups of long-term conditions that individuals had. And they found that there were 3 specific groups of long-term conditions that were associated with an increased risk of hospitalisations. And these were people with multiple cardiometabolic long-term conditions, combined physical and mental long-term conditions, and this complex pattern of multimorbidity, so the 3+3+ that I mentioned earlier. And they found that these trends were similar in patients without chronic kidney disease, but with a lower effect size compared to the chronic kidney disease group, with the exception of cardiometabolic conditions within the Welsh data. So where does the evidence in multimorbidity fit in with the guidelines that we have? So in general, there's a lack of evidence and guidelines for all individuals with multimorbidity, and this extends to recommendations in both national and international kidney guidelines as well. But I do think that within the KDIGO guidelines, it is starting to be considered in some areas. And I think the fact that even that we have the diagram that I shared right at the start of the presentation, and that's very near the start of the KDIGO guidelines, I think that really highlights it is something that we're considering, and it's something that we're increasingly seeing researchers and clinicians looking to improve and consider how we move away from the typical single organ disease specific guidelines to using evidence that can be applied in a more personalised manner to the patients that we're treating. And the work that I've been doing or focusing on in my PhD is looking at prognostic models for use in individuals with chronic kidney disease and multimorbidity. And I'm just going to spend a little bit of time talking about this with the next few slides containing some unpublished work that's currently under review. So we know from the KDIGO 2024 guidelines for CKD that it's recommended that we use externally validated risk equations to evaluate the absolute risk of kidney failure for individuals with CKD stages 3 to 5. And the most widely and extensively validated kidney failure prognostic model that we have for predicting kidney failure is the kidney failure risk equation, or KFRE, which was developed in Canada. However, from a systematic review that we have conducted, we know that the kidney failure risk equation and other kidney failure prognostic models that exist have not been validated with a focus on individuals with multimorbidity. And because of the evidence that I've already presented and what we already know about people with CKD and multimorbidity, we hypothesised that KFRE may not perform in the same way for people that have got multimorbidity, and we wanted to explore if specific clusters of health conditions impact the risk of kidney failure, or if multimorbidity might impact the accuracy of creatinine-based EGFR, and that might bias the prognostic utility of KFRE. So the study aimed to validate the 4-variable KFRE in individuals with CKD with and without multimorbidity in a research-based cohort, so again using UK Biobank, and then a population-based cohort, so we used the Stockholm Creatinine Measurement Project, or SCREAM for short. The study also assessed the performance of KFRE using EGFR creatinine, EGFR cystatin, and the combined creatinine cystatin EGFR equation to establish if cystatin-based equations added prognostication over the typically used creatinine EGFR within the KFRE model. So individuals with CKD are at increased risk of death, and as I mentioned, this risk will increase with multimorbidity and also increases with age. And when we don't consider death as a competing risk of kidney failure, you typically get an overestimation of the risk of kidney failure. So what we demonstrated was that there was a higher cumulative incidence of both kidney failure and death in the multimorbidity groups, with a prominent increase in risk of death over time compared to those that didn't have multimorbidity. This was most evident in the SCREAM cohort, which is shown in the lower 2 graphs here, where the 5-year cumulative incidence of mortality was 34% within the multimorbidity group, compared to just 11% in the no multimorbidity group. So these plots from the same study compare survival analyses that don't account for competing risks, so a typical Kaplan-Meier survival curve represented here by the dashed lines, with analyses that do account for the competing risk of death, so Allen-Johansen cumulative incidence curves represented here by the solid lines. And where you get separation between the dashed line and the solid line, where the dashed line is above the solid line, this just shows that there's, sorry, overestimation of the kidney failure risk in the death-censored typical Kaplan-Meier approach. So what these plots demonstrate is that there's overestimation of kidney failure risk in the death-censored approach, which was most apparent again in the SCREAM cohort and in the multimorbidity subgroups, but also at the higher KFRE predicted risk groups, so the purple and yellow lines within these graphs. So overall from this study, we demonstrated that multimorbidity is again common in CKD, with 61% of individuals from UK Biobank and just over 70% of individuals from SCREAM with CKD having multimorbidity. We found that KFRE discrimination was good, regardless of the presence of multimorbidity or not, but that there was miscalibration present for those with multimorbidity. We found that EGFR using cystatin C didn't impact model performance for individuals with multimorbidity that we had predicted that it might do. But given the high rates of mortality amongst individuals with multimorbidity, it was important that we explored models that account for the competing risk of death. And we found that a model that did account for a competing risk of mortality using the same 4 variables as KFRE actually improved performance for individuals with multimorbidity. So now I'm just going to spend a little bit of time talking about frailty. And as I mentioned at the start, it's hard to talk about multimorbidity without mentioning frailty. So frailty can be defined as a condition of increased susceptibility and vulnerability to stressors such as adverse events from medications or intercurrent illnesses such as urinary tract infection, and the decreased physiological reserve to be able to compensate from these, as we can see represented by the red line in the figure here. So someone experiences a urinary tract infection, and an individual that's not frail, they have the urinary tract infection, it's treated, they recover from that quite quickly, and it doesn't really impact their functional ability. And in individuals who are frail, it impacts them much more greatly. It takes them longer to recover from that, and they may not recover to the full level that they were prior to that illness. So people living with frailty experience disproportionate fluctuations in their health and functioning and are increased risk of adverse events such as falls, deliriums, hospitalizations, and then again are at increased risks of mortality compared to those without frailty. And multimorbidity and frailty are 2 separate entities and concepts, but around 6 to 7% of the general population will have coexisting multimorbidity and frailty, and around a third of adults with CKD will have frailty, with around 70% of those frail individuals also living with multiple long-term conditions. So there is considerable overlap, and it can often be difficult to separate the two when you're seeing people in clinical practice. With frailty, there's currently no unified measure or consensus for the assessment of frailty, either within clinical practice or within research. The frailty phenotype and frailty index are the 2 most extensively validated frailty measures with the largest evidence base around adverse outcomes, particularly within chronic kidney disease. The frailty phenotype is more focused on physical frailty, so assessing activity levels, strength, fatigue, whereas a frailty index is a more broader measure that captures both physical and non-physical deficits, such as comorbidities, cognitive decline, and disability. So therefore, as you can imagine, there are discordances between the different frailty measures in both the general and CKD populations. And we can visualise this in the Venn diagram on the right, which is from the work that I've been doing in UK Biobank. And here we've looked at 3 different frailty measures, so the frailty phenotype, the frailty index, using self-reported frailty measures, and a lab-based frailty index. And you can see there's really poor overlap in the classification of frailty between these 3 different measures. And as I said, frailty is common amongst adults with CKD and can influence clinical outcomes such as healthcare utilisation in advancing CKD, the risk of kidney failure and mortality. And the figure on the right is taken from a very recent review of frailty in chronic kidney disease undertaken by Nair et al. And you can see that the majority of the research today is within the dialysis population. but with some, but to a lesser degree in the kidney transplant and CKD populations. And the majority of the research focuses around mortality and healthcare utilisation, but there is now starting to be some research looking at geriatric syndromes, so things like fall and cognitive dysfunction, and I think really importantly, patient-reported outcomes and patient-reported measures. So some specific points that I think we need to consider when we're thinking about frailty and chronic kidney disease include that frailty is often associated with a decline in muscle mass or sarcopenia, and this can impact the accuracy of creatinine-based eGFR, and there's specific recommendations within the KDIGO guidelines that we should be using a combined creatinine cystatin-based eGFR equation for these sorts of patients if cystatin C testing is available and where we feel that it would impact clinical decision-making. We should remember that urine albumin creatinine ratios can be falsely raised due to a false low creatinine related to a decline in muscle mass in the denominator when we're calculating UACRs. And we should carefully consider the risk-benefit of guideline-directed treatments. And there are some areas where this is specifically considered and more personalised approaches are explicitly stated within the guidelines, such as the management of hypertension and blood pressure targets. And there are studies looking at how we can extrapolate evidence from clinical trials for these subgroups of patients. One such example is this post hoc analysis from the MBChB trial, which was published in CJSON last year. And as a reminder, the main result from MBChB trial was that empagliflozin resulted in a 28% reduction in the primary composite outcome of kidney disease progression or cardiovascular death. And from different subgroup analyses within the trial, the beneficial effects were consistent across a wide range of patient groups and different characteristics, including those with and without diabetes, irrespective of primary kidney diagnosis and across the different age spectrums that was studied. But what about people who have multimorbidity or frailty? As mentioned, we need to carefully consider what the risk-benefit profile of disease-modifying therapies are, and this obviously applies to SGLT2 inhibitors as well. And although patients with frailty might experience more side effects and have reduced life expectancy, they may actually be the individuals who gain the most from these disease-modifying drugs, because they're the individuals that are most likely to actually develop the adverse disease-related outcomes that drugs such as SGLT2 inhibitors actually aim to target. And this study used a predicted risk of hospitalisation as a proxy for clinical frailty and explored the benefits and risks of empagliflozin in people with a high predicted risk of hospitalisation, i.e. those who were more likely to be frail. And this slide shows the effects of empagliflozin versus placebo on the primary composite outcome of kidney disease progression or cardiovascular death according to the categories of frailty. And you can see that in both the empagliflozin and placebo groups, the rates of primary outcome was much higher in those at higher levels of frailty. And this forest plot shows the relative effects according to frailty, and you can see that these approximately lie within one another, lie in line within one another, and then the p-value for trend is non-significant, showing that the relative effects are consistent across the levels of frailty. But when we look at the estimated absolute effects, we see that there is a trend that emerges where the benefit of empagliflozin is greater in those with the highest categories of frailty. This slide now puts those benefits alongside the potential harms and compares these and shows the estimated absolute events avoided in the negative bars below the x-axis compared to potential harms caused by the treatments above the x-axis. And this is for every 1,000 patients treated with empagliflozin for 1 year. So the bars below the x-axis are the primary outcome and all-cause hospitalizations avoided in the light blue and turquoise, and then the 3 potential adverse events that they selected were ketoacidosis, fractures, and symptomatic dehydration. Sorry. And what you can see here is that even in those in the highest frailty categories, the benefits outweigh the risks, and the absolute benefits appear to be greatest in the most frail. And so the study concluded that the majority of patients with CKD who have frailty and multimorbidity should be encouraged and not deterred to be prescribed SGLT2 inhibitors, and that they shouldn't not prescribe them due to fear of adverse effects, because these patients are likely to be the patients that are most likely to benefit from the treatment. But I should say that there's the caveat and the limitation of the study that we should exercise clinical judgment in the most frail patients with CKD who would not have fulfilled the eligibility criteria for EMPA-Kidney. So they excluded patients, for example, with advanced cancer or with severe cognitive impairment. And so we don't actually have evidence for these very, very frail patients due to their exclusion from the clinical trials. So now I'm just going to talk again a little bit about the work that I've been doing around the kidney failure risk equation. So this is the same study design that I spoke about earlier, but this time focusing on frailty rather than multimorbidity. And here we've used just UK Biobank data because we were limited by the lack of frailty measures that are reported within SCREEN, the routinely collected Swedish healthcare data, which is a real issue that we see across frailty research, is that there is a lack of recording of frailty measures in routinely collected data, and so it's really difficult to do some of the frailty research in this area. So the study aimed to describe the prevalence of frailty in CKD population and to look to see whether the prevalence of frailty differed dependent on the frailty measure that was used, and that was what I mentioned earlier. We aimed to validate again the 4-variable KFRE in individuals with CKD, but this time looking at those with and without frailty and assessing the impact of computing mortality risk models on performance. And then again comparing the performance of KFRE using cystatin-based EGFR equations. So again, we saw that there was a higher cumulative incidence of death in the frailty groups, with a prominent increased risk of death over time compared to the no frailty groups. Here with a 5-year cumulative incidence of mortality of 8.4% in the frailty group compared to 4.2% in the no frailty group. And again, plots comparing the survival analysis where we account for competing risk, so that Alan Johansson cumulative curves in the solid lines, and where we don't account for competing risk, the dashed lines. And again, we see separation between the two lines where there's overestimation of the risk of kidney failure in the death-censored approach. Again, most apparent in the frailty subgroups and at the higher KFRE predicted risk groups, which here are the yellow and green lines. So from within this study, we showed that frailty was common in CKD, but that it differed significantly by the measures used. Again, we showed that KFRE discrimination was good, regardless of the presence of frailty or not, but that calibration was impacted by the presence of frailty. However, within this study, we did show that there was improvements in calibration when we used EGFR using cystatin C within the KFRE model, and again, models accounting for the competing mortality risk using the same 4 variables as KFRE improved model performance. So there are subgroups of patients with CKD who would benefit from cystatin C-based EGFR testing to enhance risk prognostication, and a model accounting for competing mortality risk will more accurately predict kidney failure risk in CKD, particularly in patients with frailty, and as I mentioned, in multimorbidity, and should be considered for use in clinical practice. There is, of course, so much that I could talk about in this area, and we would be here all day if I went through all the studies, but I just wanted to highlight a few other interesting publications and signposts to some of the qualitative research in this area that might be of interest to people, and people can delve into that further if they wish with the links here. So this includes work that relates to links between health literacy and the risk of multimorbidity patterns across different age groups, a narrative review that explores multimorbidity, frailty and geriatric syndromes in the context of CKD and end-stage kidney disease, which discusses some of the complexities around caring for older people with multimorbidity and frailty and looking at the use of shared decision-making. A really good systematic review of the qualitative studies summarising treatment burdens experienced by people living with CKD, but it doesn't explicitly explore multimorbidity or frailty within this, but I think has lots of issues that are really pertinent to people experiencing MLTC and frailty. And then a really interesting single-centre study by Julia Pugh and colleagues that looked at patients referred for pre-dialysis education that found 63% of patients with high clinical frailty scale died before commencing KRT. and a couple of papers exploring patient-centred care and shared decision-making in chronic kidney disease and multimorbidity. So I just want to finish by talking about where I think a few of the important future research needs and priorities are in this area. This list is, of course, not exhaustive and is very much based on my personal opinion and what I've learned and experienced during my research in the last couple of years. And I'd be really interested to hear within the discussion if there are other areas that you think that we need to be focusing on. I think further research exploring the role of albuminuria and multimorbidity would be really interesting. We know that it's a marker of endothelial dysfunction and is associated with many things, including cognitive impairment, cardiovascular disease, chronic kidney disease, but there are many other chronic health conditions that it's also associated with. And is it the chicken or egg? And does it matter in relation to multimorbidity? And are there interventions that we could be utilising to improve outcomes in multimorbidity relating to the presence of albuminuria? I touched a little bit already on the development of guidelines and trying to gain evidence for treatment in individuals with CKD and multimorbidity and frailty. And I think this is another area where we can continue to work on and try and establish the risk-benefit ratios for treatments that we're routinely offering. And this rolls into the need to explore and ensure the representation, or at very least the reporting of the presence of multimorbidity or frailty within individuals that are taking part in CKD clinical trials, given the large proportion of our patients that experience this. And I think there's more work to be done exploring frailty measures and which ones we utilise in research and within clinical practice, and the role of frailty assessment and identification in clinical decision making. And of course, frailty and multimorbidity are not static phenomena, and it's really complex. But I think frailty and multimorbidity trajectories is another massive area that we could be exploring further. My work has focused around prognostic tools and scores, and I think there's, of course, many different prognostic scores that are available, but these are typically for predicting kidney failure and mortality. But what about predicting patient-reported outcomes, or the outcomes that are most important to patients? And finally, I think that we need to think about targeted frailty and multimorbidity interventions, which are likely to be multifaceted interventions, such as changes in care pathways, development of genital nephrology teams, comprehensive geriatric assessments, shared decision-making, and how these might impact on outcomes in CKD, including the patient-reported outcomes. So just to summarise and conclude, multimorbidity and frailty are common in CKD. They're associated with a number of adverse outcomes, including hospitalisations, progression of kidney disease and mortality. However, multimorbidity and frailty are both really heterogeneous and complex, and there isn't a one-size-fits-all definition or way of managing people who experience MLTC or frailty. Definitions and measurements matter, particularly within research, but I think also within clinical practice, and the implications will vary between each individual in their own context. I think we need to be very mindful of treatment burden and the ability of individual patients to support their networks to be able to manage their long-term conditions and treatments, and particularly, as I mentioned, in the area of increasing digital interventions and a move towards more self-management. And I think we need to carefully consider how we implement the evidence-based and guideline recommendations of treatments in individuals with MLTC or frailty, where the evidence may not be implicit, and continue to do research to gather the evidence for the use of treatments in the people that we're actually treating. And I personally think it's a really important and valuable area of nephrology and general medicine, and that there's huge opportunities for future research and to develop clinical practice and services to improve people's quality of life and outcomes. I just want to finish by thanking and acknowledging my supervisory team and colleagues and collaborators in some of the work that I've presented today. But very happy to take questions and discussions around what I've spoken about today.
Thank you. Thank you for that wonderful overview of this complex topic. So if people have questions, please raise your hand and I'll call upon you to ask questions. If I can start off, about your work on the risk scores, the lack of accounting for competing risk in BANAV has always been an issue for me personally. There is, of course, I think last year, Pietro Ramani and others from Calgary presented something called KD Predict in the BMJ, which accounts for competing risk, but they only account for two comorbid conditions, diabetes and cardiovascular disease. Is that something that you could look at the KD predict also in your thing? And A and B, are you thinking of making an equation yourself? I know there are many equations. Do you want to increase the choice for us?
So I've reached out to Simon Sonney, one of the authors on KD Predict, about whether we do some further validation work with KD Predict. I think it's really difficult because it's a machine learning model, so it is much more complex than KFRE. And I think that is one of the great advantages of KFRE is really simple, and you only need the 4 variables to plug into it. And I think that's one of the reasons that it has such traction. It's obviously a very good prognostic tool in terms of it's always had really good discrimination in all of the validation studies that have been done in it. But I think the good thing about KD Predict is that it does predict risk of death as well as the risk of kidney failure. But I think what has not really been explored is how do you actually explore that with patients? How do you discuss that with patients? And we are doing some qualitative work looking at how kidney failure risk prediction tools might be implemented and discussed in people that have got multimorbidity or frailty. And I think that's a big area to be explored as well. I'm not planning on developing any tools myself, but I think just even taking the simple KFRE and adding in the competing risk to that, although it makes it a little bit more complex to actually be able to perform, I think it does improve the performance of it and is something that we should think about doing in clinical practice.
Thank you. As a sort of a semi follow-up question, how should we think about these multiple comorbidities? It could be anything. It could be lung disease. It could be cancer. Do you have anything more on, are certain types of comorbid conditions worse than other types of comorbid conditions? And partly the reason is that, the American Heart Association has this new CKM syndrome that they are trying to popularize, which just focuses, I guess, on diabetes, obesity, metabolic syndrome, or, heart disease. Are these the only important comorbidities, or, is your approach of looking at a bunch of comorbidities the right way of doing things?
Yeah, I think we need to think about both. I think within CKD, obviously cardiometabolic multimorbidities are so prevalent, and we know the risk of mortality comes predominantly from cardiovascular disease. So I think yes, they are extremely important for that reason. But I think we do also show that with increasing number of long-term conditions, regardless of what those conditions are, that your risk of death is higher and that your risk of advancing kidney disease and major adverse kidney events is higher as well. So I think we need to think about all of those, and I think we need to think just more holistically about patients and how are they managing all of these conditions. And for some patients, their chronic kidney disease won't matter to them, it won't be their priority, but is likely to still impact on their outcomes. So it's how we go about managing patients and managing what matters to them, I think is probably what's important.
That sounds good. Any other questions from the rest of the group? Oh, Greg?
Well, it's kind of what you were asking, Swap, but maybe I just want to ask Heather a different way around this competing risk, because the original paper by Tangri, which is almost like 15 years ago now, they actually, the model looked at competing risk and they said it did not affect it, so they took it out in the final model. So in 15 years, and it's interesting because like Swapnil said, I always thought that would be a huge impact, especially as you get older. And then in these models you've been looking at where competing risk seems to play a role, has the methods changed? Like it's 15 years ago, is the way to look at competing risk changed? And is there your methods versus what Tangri did like 15 years ago, are these very different methods?
I don't think the methods have changed massively. I think the ability to actually be able to develop competing risk models is now easier than it has been because people have given us papers which allow us to actually perform these models much more easily. I think what has probably changed is that we're looking at subgroups of patients where competing risk is more important, where they've looked over the whole population, and over a whole population we see it doesn't have a massive impact, but in some of the other studies that have accounted for competing risk, we see that in more advanced chronic kidney disease or in older age groups, and then here we're seeing in people with multimorbidity and frailty, that's where it matters. So I think it's the context of the patient that also matters. And I think when we then think about our population of patients that have got chronic kidney disease and the fact that actually the majority of them are going to have multimorbidity, it's thinking about what works best for the patient that's in front of us.
Okay, thanks.
Thank you. And in terms of, operationalizing for, my clinical colleagues might say, hey, what do I do with this? Is there a way for, do we just count the number of, diagnoses that are there? Is this, again, I know this is very early in the game to actually change practice, but is there any way clinically that people should start thinking about this information and how they treat patients?
And again, the Delphi consensus study touched on this a little bit, although its focus was looking at how we define multimorbidity in research. There was overlap with how we do it in clinical practice, and there are other studies looking at that. And it seems to be the simplest way is looking at long-term condition counts. Another way is that is sort of coming to the forefront is thinking about the impact on patients rather than necessarily the number of conditions they have. What is that treatment burden that I spoke about? And that's obviously going to have a bigger impact in terms of how they actually manage their conditions. But I think the simplest way is just looking at the long-term condition count. Often polypharmacy is a big indicator of treatment burden and the sort of the severity of their long-term conditions as well. So I think that's probably the simplest way for people to look at them. But I think we are lacking evidence and research out there in terms of how we can improve outcomes for people with multimorbidity. So I think that's why it makes it really difficult to say this is the best way to measure it or this is the best way to think about it, because we don't yet have the evidence to say, well, that's actually going to improve their outcomes. I think it's more about patient experience and patient treatment burden at the moment until we have further studies and further interventions that we can say are actually improving what we do for patients.
Sounds good, but I think this is a great first step to even start thinking about, the CKD multimorbidity issues and frailty, of course, which has been known for much longer. Thank you again for that wonderful overview of the topic and showing us your new research. For the audience, you will be getting an email with a link for a survey for evaluation. And we hope to meet. I hope we meet in some future conference.
Thank you so much again for inviting me and allowing me to speak this morning.
Thank you.